All right, so hello everyone. My name is Maya and I work in support services, as most of you know. Welcome to our Coast to Coast meeting. Today we have Justin Lorentz here as a guest speaker. Thank you, Justin, for giving a presentation today, and thank you to all who have joined this meeting. Before we get started, I'll just go over a bit of housekeeping. Mics will be muted during our presentation, but please feel free to send questions via the chat should anything come up during the presentation. A couple of reminders: support group meetings are strictly confidential, and any personal information that is shared here today should not be shared outside of this group. The first portion of our meeting will be recorded to share with others who were not able to attend today, but the recording will be shut off following the presentation to encourage free and open discussion, as well as to protect the privacy of all participants. A reminder as well that the facilitators, moderators, and participants today do not provide medical advice. For example, it's okay for a participant to speak about their experiences with a specific treatment, but a participant should not suggest a treatment, medication, or medical procedure to another participant. The opinions and information that are shared at these meetings do not replace the advice of a medical professional. Following the presentation portion of the meeting, there'll be time for a Q&A period. If you would like to ask a question, please raise your hand using the raise your hand function on Zoom, which can be found either under reactions or participants on the Zoom toolbar at the bottom of your screen, depending on what device you are joining us on today. When you press the raise your hand function, we will see that you have a question and call on you to unmute yourself to ask your question. And without further ado, I'll pass it on to Andrea to introduce our speaker today. Andrea has recently joined our support services team and is helping us with upcoming projects. She's great, and I'm sure you guys will all love her.
Thank you, Maya. Thank you for that lovely introduction. As Maya stated, I am a new member to the support services team, and I look forward to getting to know this group and supporting in any way that I can. Our guest speaker today is Justin Lorentz. He received his master's in genetic counseling at McGill University in 2012. He is a certified genetic counselor through the American Board of Genetic Counseling. Justin practices clinically out of the Sunnybrook Odette Cancer Centre in their cancer genetics and high risk program. He is also the lead of the Male Oncology Research and Education Program, a registry for men with hereditary cancer. His current academic interests are in hereditary cancer with a focus on male breast cancer and prostate cancer genetics. I'll now pass it over to Justin to begin his presentation. Thank you so much, Justin.
Thank you so much, Maya and Andrea, for that introduction. So, I mean, it goes without saying, I'm a genetic counselor. I'm going to share my slides here. And the things that I want to talk a little bit about today, being a genetic counselor, is genetics on the risk and prognosis or outcomes of prostate cancer. And so I run this thing called the Male Oncology Research Education Program, so a MORE program. And essentially in this clinic, we follow men who are at elevated risk for prostate cancer, whether that be because they have a family history and personal history, or because they're of certain ancestries that are at higher risk, or because they have what most focus on are genetic predispositions to prostate cancer. Okay, so right. All right, so my objectives over the next maybe, 40-45 minutes are to talk about what we are as genetic counselors. There's a few of us scattered throughout Canada, and we're a healthcare profession that not many people know about. And so giving a brief overview about that, I think, is useful. I want to talk a little about cancer in general, how cancer happens, which I think is going to be pretty much a review. I feel like the more I talk to prostate cancer support organizations, I realize how much people know. And so I think it's just going to be another perspective to hear on the cancer story from someone, at least with a genetics lens. I'll talk about genetics. This is something that most people don't know that much about. And so that would be more than an overview. And then I want to talk about genetic testing, how people can access this, whether or not the provincial healthcare system would offer that to them. And then maybe we can even talk a little bit about other ways to access genetic testing if the provincial healthcare system does not, and someone's interested in getting it. Prostate cancer genetics, how this whole concept of genetics and genetic testing applies to the world of prostate cancer. and then what we know about some of the genes that are connected to prostate cancer, how they can potentially impact treatment, how they can impact cancer risk, ways that they might change how we follow people. So let's start off with what is a genetic counselor? Genetic counselors are really specialized healthcare providers. We're kind of like nurses, but in the genetics world. So we're not physicians, we're just highly trained medical professionals in the world of medical genetics. Most genetic counselors work in the field of prenatal genetics. So families are having children, and sometimes these children are getting screened pretty regularly. These children are getting screened for any potential genetic changes. If these changes are identified, they get referred off to have a discussion about how to manage a pregnancy based on this. The other big chunk of genetic counselors work in the world of cancer, where we say, is there something genetically predisposing this family to breast cancer, to colon cancer, to prostate cancer, to ovarian cancer, pancreatic cancer? And if we find that there's a genetic explanation, we can intervene with that individual, but also with the greater family to see if there might be other family members at risk. So we have conversations about genetics. We have conversations about genetic testing. We facilitate that genetic testing, and we give people what's called informed consent, or at least we try to let people know what they're getting into when they do a genetic test like this. For some people, these are really important conversations. For other people, they say, hey, I just want the test if it's going to have any impact on my management or change. So those are the two main fields, cancer, prenatal, but we also work in cardiac genetics. We also work in ophthalmology. We work in gene-drug interactions. We work in primary care settings. So there's a whole bunch of spots for us. When we get those results back, we explain what the results mean for people and implications for them and their families. We take these things called pedigrees, which is a term that we use all the time, and for us means nothing more than what it is. But when I say things like this, people think of dog food. And so we also call them family trees. Family trees are just basically ways for us to document or easily write down on one piece of paper a person's family history. And that is incredibly insightful for us to be able to assess whether people are eligible for genetic testing, to assess whether or not we think that the cancer in the family may be what we call hereditary, or maybe it's just happens by chance, sporadically we call it. And so we denote individuals using their gender. So female gender is a circle, male gender is a square. This little arrow shows that that's the person of interest, and everything works in generational lines. So here's one generation, you go generation below, son, daughter, nephews. You go generation above, father, mother. And on mom's side of the family, we have aunts, uncles, and dad's side of the family, aunts, uncles.
Okay, and so in family histories, we're interested in documenting these generational lines. We tend to shade in people who have had cancer so that we know to pay a particular focus to them. And then we're also interested in knowing about someone's ancestry. So up here on mom's side of the family, we have Italian ancestry. On dad's side of the family, we have German or English, Irish ancestry. Certain ancestries are are at higher risk for certain types of cancer. And so there's important information for us to ask for to help with determining risk and whether or not people are eligible for genetic testing. I have something chat here. Oh, good. Okay, yes, that's good. All right. So what is cancer? Cancers are every time genetic. Every cancer is due to a genetic mutation that happens. And oftentimes it's actually many genetic mutations that happen. And what happens is we have a normal cell. Let's use an example of, say, a skin cell. And that normal skin cell, its genes are almost always perfectly pristine. But over life, that gene will be exposed to things that cause mutations to occur, whether it's UV radiation that hits the skin and causes genetic mutations, or maybe it's when the skin cells just divide. In the process of dividing, the genetic information causes a really rare chance of a mutation happening. What we know is that our cells will accumulate mutations throughout our lives. However, if we accumulate mutations in genes that protect us from cancer, then those genes can't do their job of protecting us from cancer, and these cells might go down this process of becoming cancerous. A cancerous cell essentially just divides rapidly. It forgets what its job is, forgets to be a skin cell, and then just becomes this kind of selfish entity. It goes rogue and it starts dividing uncontrollably, collecting resources, and then eventually moving to other parts of the body and doing the exact same thing. And so when there is this kind of growth that happens, there are mutations within all of these growing cells. And oftentimes, these cells will have what we call little colonies themselves, where the cells at the bottom of the tumor might have some different genetics than the cells at the top of the tumor. And there's always this kind of evolutionary process of more mutations happening inside that tumor. And so whenever we sample a cancerous tumor, we find all these different mutations. And if we sample the skin tissue right next to that tumor, we'll find very few or no mutations. And so all cancers are when healthy cells kind of go rogue and accumulate mistakes or mutations. That accounts for what we call sporadic cancer, or cancer that happens by chance. 70 to 80% of cancers happen just purely by chance. Bad luck, bad mutations happening in the wrong genes. And it's a serendipitous event. It's a 1 in a billion chance that we're going to get cells that accumulate these mutations, but when we have billions and billions of cells, the odds eventually check out over time. Only 5 to 10% of cancers are what we call hereditary. Hereditary means that there's a genetic mutation in one of these cancer-protecting genes that was passed on from generation to generation. We inherited that gene mutation from either mom's egg or dad's sperm. And as a result, when the sperm fertilizes the egg, boom, every single cell that makes us has this genetic mutation. Now, having a gene mutation in one of these cancer-protecting genes does not mean someone's going to get cancer. It just means that the process, that natural process of cancer occurring is just a little more likely. And so these people are more likely to get cancers. The other type of thing that can cause cancer is what we call familial cancers. This is too complex for us to understand. Multiple genes, slightly increasing risk that we can't detect at this point in time. Now, when it comes to prostate cancer, most prostate cancers actually happen because of either chance, sporadic, or actually familial. Very few cancers, prostate cancer specifically, are hereditary. It's less than 10%, maybe about 5%. And familial, it's probably more like 20, 25%. But this information just shows cancers in general. So I made reference to genes. We all know what genes are, peripherally. We live in 2023 and people talk about genes all the time. But really what genes are really long strands of DNA. They have instructions that tell our body how to grow and function. There's about 20,000 genes that make humans humans. And we get one copy of our gene pair from mom and one copy of our gene pair from dad. So that's why this picture here of the gene, there's 2 copies holding hands, because we have 2 copies of almost all genes. Most genes are perfect. They don't have any mistakes or mutations in them. And I know that's true for everyone, because if we're all sitting in this Zoom meeting having a conversation, most of your genes have to be working just fine. Some genes have mistakes or mutations in them. And mutations are basically just changes that are problematic. We call these pathogenic variants. To break that word down, pathogenic means problematic, variant means change. So a problematic change in a gene, genes with pathogenic variants. The reason why I even use that language is because when people do genetic testing and they get reports back, sometimes they see that language and it's helpful. There's other languages that can be used to describe changes or variants in genes. One of them is called an uncertain variant. Sometimes people will see that when they do genetic testing. So Warren from Edmonton just asked if several cancers are caused by viral infections like HPV. How does that fit into the 3 categories? That fits into the sporadic, happening by chance. And so it's chance that you got impacted by HPV, and so it kind of fits loosely into that category. And so that's more of an environmental component that's attributed, just like lung cancer and smoking. We could talk a little more about HPV. It's not the focus of this talk, but it's definitely an interesting talk in and of itself. So how are genes passed on? Here's an image of a female and a male, and they're both parents. They're both going to have kids. They each have 2 copies of, let's say, a cancer protecting gene. One of the more commonly well-known ones is the gene BRCA2, or the breast cancer 2 gene. People call it BRCA. So this woman has 2 working copies of the BRCA gene. This man has a mutation denoted by that red spot on one of his genes. Now, when they go on to have kids, it's a 50-50 chance over which gene gets passed on. So sperm only contain one of those copies. An egg only contains one of those copies. It's a 50-50 over which copy the sperm of the egg has. So this woman, she's either going to pass on the gene copy without the mutation or the other gene copy without the mutation. But the male partner is going to have a 50% chance of passing on the gene copy without the mutation and a 50% chance of passing on the gene copy with the mutation. So this 50-50 chance is a recurring theme in most forms of cancer genetics, where if someone has a gene mutation, there's a 50% chance they pass it on to the next generation, 50% chance they don't. So that's the genetic piece to it. How do we find out whether or not someone has one of these gene mutations? Well, to do that, we have to do genetic testing. And genetic testing can be done by getting a tissue sample from an individual and analyzing the genes within it to see if there's any problems in those genes. Now, some of the easiest tissue samples to get actually are blood or saliva. But when we get a blood sample or a saliva sample, what are we actually testing? Well, blood's made up of serum or fluid that has no DNA in it. It's made up of red blood cells that also actually have no DNA in them, but it's also made up of white blood cells. They're called leukocytes, and these actually do have DNA. Leukocytes actually originate from bone marrow. So by getting a blood sample and sending that off, we're actually secretly sending off a bone marrow sample. And the scientists read through the genes in the white blood cells to see if there's any mistakes and mutations. When we get a saliva sample, same thing. There's some buccal cells or skin cells that are in the mix, but mostly it's also white blood cells. And those are sent off and analyzed. And so sometimes some genetic testing can look like a saliva test or a blood test. Doesn't matter. It's always the same. Now, what are these testing? These are testing our bone marrow cells. And it's really just as useful as doing a skin sample. They could test skin cells, bone marrow cells, eyelash cells, eye cells. It doesn't matter what they're analyzing because these are gene mutations in healthy cells, and every gene that we test, every type of cell that we test should have the same genetic information that we were born with. So we're looking to see if there's anything that we were born with that has mutations. We call this germline testing. Germ comes from sex cells, either sperms or eggs. If we find that there is a mutation in one of these genes, we say, okay, you have an inherited predisposition to cancer based on this gene mutation. This can be passed on to other family members. If you do not have a gene mutation and you have cancer, then I say, hey, of the known gene mutations that cause hereditary cancers, we didn't find anything. So your cancer may have happened either by chance, sporadically, or because of these minor genetic factors that we don't know too much about. Now, people could do another type of testing. It's called tumor testing, where the scientists will actually take a biopsy of the tumor and send that off for genetic testing. Every time they send off a tumor test for genetic testing, they're going to find many mutations because, as we discussed before, all cancers occur through multiple mutations that occur within a once healthy cell. And so they're always going to find a whole bunch of mutations in that. Some people, when they get their cancer tested to see whether or not there are mutations there that can help target therapy. And so that's also a genetic test, but it's not the type of genetic test that genetic counselors do. We're focused on the germ cells, the ones that you're born with, not with mutations that occur in a cancerous tissue that accumulate over time. So how do we go about doing genetic testing in a place like Canada? Well, you have to meet criteria to get genetic testing done. And in Ontario, we came out with criteria a year and a half ago for all different types of cancers, including prostate cancer. And one of the main one is actually criteria number 1, having a personal history of metastatic prostate cancer. And that's prostate cancer that's spread to other parts of the body. There's a bunch of other criteria that people can have. They have a personal history and a family history. They may have cancers in the family that aren't just prostate cancer, but also maybe pancreatic, ovarian, or breast cancer. And so those are the criteria in Ontario. I also quickly grabbed some criteria for British Columbia. And we can see here, this is a referral form to a BC Cancer Agency. And they say if someone has a personal history, you tick off this box and it says metastatic prostate cancer, boom, that's a good reason to be referred over to genetics. And so at this point in time, a universal thing in Canada is if someone has a really aggressive metastatic prostate cancer, that's an indication that there might be something genetic going on that caused that. And the reason is because most prostate cancers are not metastatic. It's rare that they do. And if this is present, then we start wondering, could there be something also rare going on that explains it? Could there be some inherited genetic mutation? And that all came about from this study that was done. I stole these slides from a medical science liaison who really described the information well. And back in 2016, this person in the US from Johns Hopkins basically studied 700 men who had metastatic prostate cancer and did genetic testing on them. And 12% of them have a gene mutation that they were born with. And that is a huge number. 12% in the world of genetics is a really strong indicator, and it's a reason to have people get testing done. And so for that reason, over the years, Canada decided, yeah, this is probably the right thing to do. Now, not all provinces are on the same page. I just finished writing a paper with a group of experts in the world of prostate cancer to make that recommendation throughout the country, but every provincial healthcare system has their own thing. However, when it comes to metastatic prostate cancer, I think every province is on board now with offering genetic testing. Some provinces have are less strict, and some are more strict depending upon the province for who's eligible for genetic testing. But the world of genetics is always changing. And so what we recommend now could modify in the future, and that modifies with our understanding of genetics and impacts clinically. So for example, there was a study that came out that showed that there's a really specific type of prostate cancer that's also connected with being with these inherited or hereditary cancers. They found people who have this thing called intraductal histology. 14% of men had a gene mutation. And so we were deciding whether or not we should include that as a criteria as well. And then a paper came out a few years after, 3 years later, that said, actually, that's not true. We think that this is more of a finding that's present in the cancer itself, not something that people are born with. And so things are constantly changing in this world. And so that's why these talks are nice, because even if you're hearing the same person talk, there might be something new that came about a few years later that's being discussed. And so we used to think about this intraductal or cribriform histology as being associated with inherited gene mutations, and now we don't think that's the case as much anymore. So sometimes when people do genetic testing, they say, hey, well, if you do find that I'm genetically predisposed to something, could life insurance companies use this information against me? What about critical illness? And we're actually protected under a federal law that came into place in 2017 and then underwent litigation and became law later on. And it's called the Genetic Non-Discrimination Act, and it prevents life insurance, critical illness insurance companies from using its genetic information against you. It's a medical test, but it's a medical test that they can't access or look at, or at least use against you. However, people can still use your personal history and family history against you. That's part of that's all fair game for discrimination when it comes to these insurance companies, but not genetic test results. We're protected there. So I want to talk a little bit about the groups of people who are at risk for prostate cancer, and there's 3 of them. First group, and to me, it's the highest risk group. These are men who have a family history of prostate cancer. So this chart here uses this thing called RR, and that means relative risk, or risk relative to the general population. And the 3.4 means 3.4-fold increased risk. So what's the general population's risk for prostate cancer? If you believe Statistics Canada, it's 11 to 12%. Every man has 11 to 12% lifetime risk. Any man who has a brother that was diagnosed with prostate cancer, that risk is 3-fold higher. So that puts that man to over 30% lifetime risk. There's another acronym that's used here. It's called FDR. That means first degree relative. These include siblings and parents. So any man with a father or a brother with prostate cancer, it has a 2.6-fold increased risk. Any man who has 2 affected first degree relatives, so for example, a father and a brother, that man has a 5-fold increased risk, so over 50% chance of getting prostate cancer himself. This is the biggest predictor for prostate cancer of a man who has a father and a brother with prostate cancer. or two brothers with prostate cancer. No gene mutation can tell someone their risk is as high as that. The thing about this is that it doesn't necessarily quote what the aggressiveness is. Most prostate cancers are not typically known to be aggressive. They can be monitored in something like active surveillance without being treated. Now, the other at-risk group are individuals of West African and Caribbean ancestry. Some studies will say individuals, African Americans, and that's not necessarily true. The data is that it's mostly individuals who are coming from West Africa, not all of Africa, and not the south of Africa, but West Africa and the Caribbean. And so, what do these geographical areas have in common? It's the slave trade. And so a lot of individuals from West Africa were brought in as slaves to the Caribbean. And so these are two kind of different areas in the world, but one thing that there's a commonality is the genetic similarity from West Africa. And so could it be that it's this genetic predisposition that came from West Africa into the Caribbean that is where the risk is, and there's something underlying genetic that's increasing risk for prostate cancer. And so there's this really beautiful depiction of this one is incidence, or the amount of prostate cancer that we see in the world, where it's a heat graph. And so the warmer the spot, the higher the incidence, the cooler the spot, the lower the incidence. We see high incidence in Scandinavia, Europe, North America. We see some hot spots in some parts of South America, and we see some mild parts in West Africa. Now, incidence means that people are screening for it and actively looking for this. Some places there might be high incidence, but there just isn't a healthcare infrastructure or reporting for us to be able to identify these cases. And sometimes people just go undiagnosed and pass away without an explanation. This is a map of mortality, people who have died from prostate cancer. So incidence, mortality. What you see is that even in places like North America, where there's a high amount of prostate cancer, not a lot of men are dying because of their prostate cancer. However, if we flip between, we're noting in West Africa and the Caribbean, we're seeing high rates of mortality. So these are men who are getting aggressive prostate cancer. Now, is that due to something genetic? Maybe. Could it be due to a bunch of other factors that we're kind of exploring now? Perhaps. So whatever it is, this population is at an elevated risk for more aggressive disease. And so it's a population that we're interested in the world of genetics to see, is there something genetically, predisposing people here. Scandinavia, we see this, a little bit more of a higher rate of mortality. The question there is, could there be something genetic? There is some founder genetic mutations in Scandinavia, but I don't know if that accounts for what we're seeing there. So there's another kind of interesting thing. I kind of explained before how prostate cancers are largely familial, and what that means is that there's largely these minor genes that are slightly increasing risk. And this study shows that really well. So what they did is they basically quantified or put a value or number behind something called heritability. Heritability is the amount of genetic differences there are between people who have something in common. So in this case, it's cancer. If people have some type of cancer in common, how genetically similar are they? A really good way to study this is actually looking at twins. Identical twins are genetic clones of one another. They have the same DNA. That's why they look identical. Fraternal twins are twins that are born at the same time, but they're actually siblings. They are genetically different from each other. They're siblings. And so if you study cancer in identical twins versus fraternal twins, you can start teasing out what cancers are likely due to something genetic, which cancers are likely not due to something genetic, or what degree of genetic comes into play. If an identical twin set of men both get prostate cancer at the same age, then I say the chances of there being something genetic there is quite high, particularly when I compare it to fraternal twins, where one just gets prostate cancer, the other one doesn't. And I'd say, maybe there's not as much of a genetic piece here. And so by comparing these same identical twins versus fraternal twins, we can start teasing out how heritable certain cancers are. And prostate cancer ends up being one of the most heritable cancers. We all talk about how breast cancer has a high genetic component. Well, it only is 0.3% heritable compared to almost 0.6% of prostate cancer. So there's definitely something genetic and probably lots of things genetic going on, but we're just not that good at teasing that information out. Right now, genetics medicine is focused on monogenic, meaning single gene, single mutation outcome. We're just looking at one change. We're really getting simplistic. We haven't been able to figure out this polygenic, multiple genes that are associated with a health outcome. Prostate cancer probably is more polygenic than monogenic, but all we can study this time, or right now, is monogenic. So let's get into it. The genes that we think about that are associated with prostate cancer are listed here. HOXB13, BRCA1, BRCA2, MLH1, MSH2, MSH6, PMS2, ATM, CHEK2. It's all code garbage. These are really small acronyms that scientists put together because they don't want genes to be long names because we have to use them frequently. So they get these little small coded areas. HOXB13 is the only true prostate cancer gene that's hereditary, that provides a hereditary risk for prostate cancer. Because at this point in time, based on what we know, all that this gene does is elevate risk for prostate cancer, and that's it. Other genes like BRCA1 and BRCA2, made famous by Angelina Jolie, who has a BRCA1 gene mutation, these genes are associated with breast cancer. They were named after that, the breast cancer gene. Also ovarian cancer, prostate cancer, and pancreatic cancer. There's two of them. BRCA1 was the first to be identified. BRCA2 is the second to be identified. Another person who has a BRCA gene is, is it Matthew Knowles? Yes, Matthew Knowles. This is Beyonce's father. Beyonce Knowles' father. He was found to have a BRCA2 mutation because he had breast cancer and then got genetic testing. Now, Beyonce and her sister Solange don't have this gene mutation, but the genes, they don't care whether or not they're living in the body of a man or a woman, and they can increase risk for cancer in both men and women. However, we see the highest risks for cancer in women. This is Mary Claire King. She helped identify the BRCA1 gene mutation. BRCA1 and BRCA2 cause this condition called hereditary breast and ovarian cancer syndrome. It's a big term. They call it HBOC, but in no way in this title do they mention pancreatic cancer or prostate cancer. And some people think that's why there's such a difference in the amount of people who are tested. 218 women to every 12 women, to every 12 men are tested. It should be 50-50. There should be 218 men and 218 women tested. But the BRCA genes impact risk for cancer and cause higher rates of cancer in women than men. And the cancers end up being a little more severe in diagnosis between women and men. And so that might be a reason for why. But her name is Mary Claire King, and so they wondered, well, hereditary breast and ovarian cancer syndrome is very gendered. Maybe we should call it King syndrome to make it more universal. But King syndrome is also very gendered, and so it's probably going to stay as hereditary breast and ovarian cancer, and the genes are probably going to stay as the BRCA genes, even though they impact PRCA or prostate cancer. The other genes that are impacted are that impact risk for prostate cancer are the genes that cause a condition called Lynch syndrome. Now, this condition used to be called hereditary non-polyposis colorectal cancer syndrome, HNPCC, which was a mouthful, and they said, well, let's name it after the person who invented it, Dr. Lynch. Lynch is also not a good last name, but they decided to use that as the name instead of calling it HNPCC because this gene, Lynch syndrome, or the genes that cause Lynch syndrome, cause risk for much more than just colon cancer. They increase risk for prostate cancer, pancreatic cancer, and other cancers as well. The genes that I care most about when it comes to Lynch syndrome are the genes MSH2 and MSH6. There's a new study that showed that these are the ones that we care, that have the highest prostate cancer risk. The other genes that we think about are the genes called ATM, like an ATM machine, which increases risk for prostate cancer, and then the other one, CHEK2, not CHEK1, but CHEK2, which we see an elevated risk for prostate cancer. And there's a common genetic mutation that we see in people of Eastern European or just European ancestry. So what I've done is I've kind of just given these plus signs to show how much of an increased risk there is. BRCA2 and HOXB13 are the biggest players. BRCA1, not so much of an elevated risk. ATM and CHEK2, not so much of an elevated risk. And then the MSH2 and MSH6 genes, more of an elevated risk. So why would anybody want to get genetic testing for this? To see if they have any of these gene mutations. Up front, it can give us an understanding of why someone got prostate cancer. Sometimes knowing why is one of the things that people kind of, rack their brains trying to figure out. Was it because I did this throughout life? Did I not eat enough of this? Did I eat too much of this? Oh no, I have a genetic predisposition to it. That's why. The other piece is that if someone does have a gene mutation, then we can test other family members to predict what risk is for other family members. And more importantly, we can also, say, hey, well, I have this gene mutation, but you don't. And so therefore, I'm not as concerned about your risk for prostate cancer. And I'm specific with my language there because having a family history of prostate cancer is still significant, even if you don't have a gene mutation that the family member has, and we still want people screened for prostate cancer. Also, these genes might be connected to other cancers, like BRCA gene is connected to breast cancer and ovarian cancer in women. So if a man has prostate cancer and has that gene mutation, and he has daughters, and I'm worried about risk for daughters. Or if that man has a gene mutation in one of these genes, I'm now concerned about his risk for male breast cancer if he had prostate cancer. Or I might be risk for his concerned for his risk for pancreatic cancer. Other important pieces of information can be, well, does this gene mean that my prostate cancer is more prone to being aggressive? And if so, should my doctor treat me differently? That's an insightful piece of information that we can get from that. Sometimes doctors may choose whether or not to put someone on active surveillance based on their genetic status. Maybe they may opt to favor surgery over radiation if there's an option, and if a patient's a good candidate for either modality, a type of therapy, they may favor one over the other based on the gene status. Maybe people might be eligible for drugs that target and kill cancer caused by these gene mutations. So let's use that same kind of chart and walk through some of the different things that we talked about. Aggressiveness, HOXB13, the data is not there yet to show that people with these gene mutations get more aggressive prostate cancer. People with HOXB13 mutations maybe sometimes get prostate cancer a little bit earlier and therefore could get more aggressive disease, but the literature is not conclusive at this point in time. BRCA1 and BRCA2. BRCA1 we used to think caused aggressive prostate cancer, but more data is coming out to suggest that it might act similar to the general population. The data is still conflicting, and so it's a bit of a question mark, but the data is very consistent in saying that any man with a BRCA2 mutation will always get aggressive prostate cancer. And so we know that that's a big marker for that cancer becoming aggressive. And so if it's picked up early, then some people might want to manage it a little more aggressively. With the genes for Lynch syndrome, there's still lots of debate about aggressiveness for some of these genes. For MLH1, MSH2, there's no data at this point in MLH1 and MSH6. There's not enough. We don't think so. For MSH2, it's debatable. For PMS2, we know that that's not the case. For ATM, still a bit of question mark. There's one study that came out that said maybe people on active surveillance might not be good candidates for active surveillance if they have an ATM gene mutation, but that data was kind of weak. For CHEK2, there's no evidence that cancer is more aggressive. So speaking on active surveillance, there was that one study that I made reference to. It showed that men with ATM, BRCA1, BRCA2 gene mutations were more likely to have their prostate cancer become more aggressive earlier while they're on active surveillance. And so when someone's on active surveillance, if they call it a reclassification of their prostate cancer, it goes up a grade group or goes up a Gleason score, that's a reclassification. People with these gene mutations are more likely to reclassify. Having said that, this study was, although it looked at all three groups, the data was most conclusive for just BRCA2. ATM and BRCA1, the data was not nearly as conclusive. And so really, it does say that active surveillance people are more likely to be classified if they have BRCA2 gene mutations. But although ATM and BRCA1 were in the study, the data actually doesn't really make that suggestion at this point in time. So it's a bit of a question mark. It needs to be further studied. Truly, it's kind of the Wild West. Would people change recommendations for radiation versus surgery for ATM or BRCA1? Probably not. But for BRCA2, one of the benefits of surgery over radiation is that when you do surgery, you can remove the prostate and do a full pathology review. And that may be more important for people with BRCA2 mutations in case there might be some type of more aggressive prostate cancer within the prostate that couldn't be identified. And so that's kind of where we're thinking now, but there's no recommendations, there's no rules. It's the Wild West, particularly in Canada, on how to manage people in that way with these gene mutations. But what about systemic therapy? Systemic therapy is treating the whole body for something like a metastatic disease when it comes to metastatic prostate cancer. And there are drugs that target and kill cancers caused by these gene mutations that people inherit. For BRCA1, for BRCA2, for ATM, there's a drug called a PARP inhibitor that can be used. And people who have gene mutations in these BRCA1, BRCA2, ATM genes may be eligible for these drugs as a line of therapy if they have metastatic disease. For Lynch syndrome, there's another specific set of drugs that targets and kills cancers caused by mutations in these genes. If someone has a Lynch syndrome, this might be good information for them to be able to tell their healthcare provider. Now, the studies available for Lynch syndrome and prostate cancer, people with metastatic prostate cancer with Lynch syndrome, access to these medications, they're called anti-PD-1 or programmed cell death inhibitors. It's not easily accessed in Canada. This is something that there's more research going on in the US, but you could always ask if there might be clinical trials that are happening in your hospital if someone does have Lynch syndrome. And so it's a good kind of thing to keep at the back of one's mind. Okay, so I told myself that I would leave 10 to 15 minutes for questions. And so we're nearing that area now. I'm seeing one question in the chat group, but I'm wondering if anybody else might have any other questions.
Let me just hop in here. Thank you, Justin. I appreciate